Pleasure and privilege to introduce Singh to lead our rounds today. He'll be speaking on advances in electrical therapies for heart failure, two really important areas of cardiology. I had the privilege of training under Jag while I was at MGH, and like many others, I continue to learn from him today. The combination of his intellect, his kindness, and his humanity is possessed by few, and he really is a true leader and mentor to many in the EP field. Jag's a professor of medicine at Harvard. He's the former clinical chief of the cardiology service and the Roman DeSanctis Endowed Chair in Cardiology at Massachusetts General Hospital. He is the founding director of the Resynchronization Advanced Cardiac Therapies program at Mass General, which is a world-renowned program treating patients with heart failure and defibrillators. Jag received his MD training at the BJ Medical College in Pune, India. He then completed internal medicine, cardiology, and electrophysiology at Mass General Hospital. He obtained a doctorate from Oxford and a Master of Science in Clinical Investigation from the MIT Harvard Research Program. To say he's a well-recognized scientist and educator is an understatement. He's presented over 450 lectures at international conferences and frequently leads many Meet the Masters programs. His research interests include various topics in cardiac electrophysiology, and he's a principal investigator for multiple multi-center ongoing trials in device therapy and sensor studies for heart failure and atrial fibrillation. With this, I'll pass it over to Jag to give his talk today. Thank you, Jag, for coming.
Thank you, Sheldon. Really appreciate it. I really, it's an honor to be here, and it's an honor to connect with you again in person, and I really appreciate the invitation. I'm guessing you can all see my slides. Is that?
Yeah, it's great. And also for the audience, if you want to ask a question, please send it to the chat room. I told Jack that we're going to maybe take a couple of short breaks during the presentation for questions somewhere during, so we can break it off a little bit, and probably at the end. So just you can just email me in chat. I can call on you later on if you're interested. So I'm sure there's a lot of things that you would like to ask. So thanks a lot, Jack.
Absolutely, absolutely. Feel free to interrupt at any stage, and I'm happy to answer questions as we're going along and as well as at the end. So thank you again. So my onus for today is to really kind of expand on advances in electrical therapies for heart failure. And within this set of topics, I'll be touching on many aspects. One is talking about resynchronizing the failing heart. I'll briefly elaborate on conventional cardiac resynchronization therapy strategies, as well as newer pacing approaches. Beyond that, I'll talk about some of the other electrical therapies that include neuromodulation, cardiac contractility modulation, as well as stimulation of the phrenic nerve for sleep apnea, which accompanies heart failure oftentimes. And then this was a special request by Sheldon to really kind of touch on multidisciplinary care, since I know we're a mixed audience out here. He wanted me to talk about the need and the construct of a multidisciplinary integrated clinic between EP, heart failure, and general cardiology, and how this could potentially be used in predicting and preventing heart failure. So why the need for advances in electrical therapies? So I think we all recognize that there's a progressive increase in the incidence of heart failure. There's a huge drain on the national exchequer. We also recognize that left ventricular assist devices are expensive, technically difficult, have huge lifestyle changes that impact patients who get them. And then cardiac transplant obviously has its own limitations in terms of availability of donor organs. So a lot of issues out there, and that's why resynchronization therapy really, and the other electrical therapies really come into play out here. So for those who are not electrophysiologists and not completely familiar with resynchronization therapy, let me kind of just give you a very brief overview. This is the electrical activation sequence of the heart. So this is how the ventricles are getting activated. This is the mechanical contraction of the heart. So when you have abnormal electrical activation, when you have a wide QRS or a left bundle or any wide QRS, you land up having a mechanical contraction, which is kind of not optimal. You can see out here, there's an EKG with a wide QRS, and you can see the heart kind of rotating on itself out here. And this is called mechanical dysynchrony. So electrical dysynchrony translates into mechanical desynchrony. Mechanical desynchrony with the accompanying mechanoenergetic inefficiency results in progressive reduction in heart function and oftentimes translates into significant clinical symptoms. And that in turn can lead to heart failure hospitalizations and mortality. Now, when we talk about electrical abnormalities, there are, several levels of this electrical desynchrony that can occur in the atrium, between the two atrium. It can occur between the atrioventricular desynchrony. It can be interventricular desynchrony as well as intraventricular desynchrony and intramural desynchrony. So when we look at resynchronization therapy, this is a coronary venous angiogram out here. And what CRT involves is putting a right atrial lead, putting a right ventricular lead and a left ventricular lead down one of these coronary sinus branches so that the heart can get coordinated activity between these three electrical spheres within the heart. But what we're trying to do is really correct all these levels of electrical desynchrony, which is, fairly challenging. So it is a simplistic fix for a complex problem. And that's why I think there are many other electrical therapies that need to really come into play. Now, the important thing about CRT, and I think many of you have already heard that response is not 100%. There are about 20 to 25% of patients that don't necessarily get adequate response to CRT. And a part of that is selecting the right patient, implanting the lead in the right spot, and then the multidisciplinary care with device programming and appropriate follow-up are really important components of ensuring that the patients get the best out of their devices. So let's touch on each one of these aspects to kind of give you a sense of why each of them are important in enhancing response to resynchronization therapy. So this is the ECHO CRT study, which I think many of you must have heard of. I know there were many Canadian institutions also involved in this study. This is a study that we did looking at resynchronization therapy in patients with a narrow QRS, with a QRS of less than 130 milliseconds, but with mechanical desynchrony by echocardiographic measurements. And what we found was that, resynchronization therapy did not work as well when you used just mechanical desynchrony as a selection feature. And you can see out here, there was no difference in the control arm of over 800 patients between CRT and control. And in fact, patients who got resynchronization therapy did poorly as compared to those who did not get resynchronization therapy. Again, bringing up the point that resynchronization therapy is an electrical fix for an electrical problem. And we need to be really looking at what the QRS interval kind of gives us an idea of what the electrical activation sequence in the heart is. Now, not just is it the narrow QRS that doesn't do as well. There are many meta-analyses, and this is really a large one in about 25,000 Medicare beneficiaries, which showed that patients who had not only a narrower QRS, so less than 150 milliseconds, but also who had a non-left bundle branch block, so where the activation sequence of the heart was not like a left bundle branch block, and I'll explain that in 2 seconds, actually did poorly, as you can see, compared to patients with a wider QRS and compared to patients who are a left bundle branch block. So again, indicating that not only does the QRS width or the extent of electrical synchrony matter, but what kind of electrical desynchrony there is also matters and how patients will respond. To that end, let me just kind of explain to you what I mean by that and why there is this differential response and how people respond to resynchronization therapy. So if you look at, for those who are non-electrophysiologists, let me explain what this map out here is. This is an electroanatomical activation map of the right ventricle and the left ventricle. We put catheters in the heart and we can look at the electrical activity within the heart. The earliest part of the heart to be activated out here is the red area, that's the right ventricle. And the last portion in a left bundle branch block to be activated is the lateral or the posterolateral portion of the heart. Kind of makes sense. When you have a left bundle branch block, the last portion to be activated is the posterolateral portion of the heart. When you have a right bundle branch block, it's flipped over completely. Obviously, the left ventricle gets activated first and the right ventricle gets activated last. And when you have a combination, you can oftentimes have delayed activation on the right ventricle as well as the left ventricle. And the reason I bring that up is that it's so important that when we're treating our patients, that we recognize what the conduction defect is, and then we try to individualize our treatment strategy, because it's not a one-size-fits-all strategy. And because it's not a one-size-fits-all strategy is why we have this differential response within patients. And most of us electrophysiologists want to just get in very quickly, put a lead very quickly, come out very quickly, and then hope that the patient does well. And I think the important thing is to select the right patient and then implant the lead thoughtfully, depending on what the electrical activation sequence within the heart is. And much of those electrical activation sequence measurements can be made even within the heart, within the coronary sinus. And I'll show you what I mean by that. Now, there are many levels of response, and response is not a responder and a non-responder. It's not dichotomous. It's actually, I would say, it's a continuum. You can have a super responder, a patient whose ejection fraction normalizes completely. You can have just a responder with a good response. You can have a non-progressor, so a patient who was getting repeatedly hospitalized for heart failure is now not getting admitted because the CRT is working, but the ejection fraction has not changed a whole lot. And then obviously you can have patients who do poorly or don't respond at all to therapy whatsoever. Now, there is a gradation in how you select which patients respond and which patients don't respond. And from the patient selection perspective, I think it's important to remember that patients who have a wider QRS, patients who have a left bundle branch block, women, and non-ischemic cardiomyopathic patients actually do much better. As the QRS narrows, as it becomes a non-left bundle branch block, as we just saw from the meta-analyses in those graphs, those patients don't do as well as those with the non-ischemic cardiomyopathic substrate. So just taking this a little further, this is a study we just completed, recently published now 2 years ago. It was a late breaker at the Heart Rhythm Society. It's called the Made It CHIC study, the CHIC standing for chemotherapy-induced cardiomyopathy. And this Made It study really was to select those subsets of patients who have survived cancer, but now go on to develop heart failure with widening of the QRS. And oftentimes these patients were considered as orphans by the system and just left saying, you had cancer, now you have heart failure, too bad. So we decided to create a multi-center study involving 12 different cardio-oncology studies with centers within the US, recruited a bunch of patients, about 34 patients, so who were then subjected to resynchronization therapy. And lo and behold, we found that these patients did really well. Across the board, there was an improvement in ejection fraction, and irrespective of the underlying covariates, patients who got resynchronization therapy did well. And about 87% of these patients were women, majority of them having had breast cancer and been exposed to adriamycin and other chemotherapeutic agents, which we know are cardiotoxic. So just to give you an idea that conventional patient selection is important, but it's also important to recognize that within that realm of patient selection, we need to be able to individualize our treatment strategies because there are a lot of patients who can still benefit from electrical therapies. So going beyond patient selection, I think targeting the right area of electrical delay within the heart with resynchronization therapy is really important again. This is that same activation map that I showed you, but this is done with a catheter inside the coronary sinus, where when you put the catheter into the coronary sinus, you can actually measure the electrical delay within the heart. And you can see out here, this area in the posterolateral portion of the coronary sinus is delayed, and there is scar out here, which is red out here. This is a voltage map. And by determining that, you can find the most optimal location in these patients as where they would benefit from resynchronization therapy. Now, we took this a step further, and as a part of the SMART AV study, we did something called the QLV, where you measure the electrical delay with the LV lead. And we were able to show that if you get the lead in the area that has maximal electrical delay, those patients actually translate into doing much better. They have an improvement in their ejection fraction, in their end systolic volume, in their end diastolic volume, as well as quality of life, much better than patients who had a lead which was not in such an electrically delayed situation. Now, when we talk about resynchronization devices in heart failure, I think it's really important that as we get better at this, we need to be understanding the phenotypic characteristics of the myocardium and the electrical conduction tissue disease much better. And I think that's because there are different therapies now that are evolving for resynchronizing the heart. This could be left bundle pacing, which goes all transeptally all the way across and paces the left bundle. This could be his bundle pacing, where you get the lead at the His bundle, and then there can be multiple endocardial sites out here. And this is an endocardial pacemaker out here, or endocardial lead out here that can be paced to again resynchronize the heart. And so many options coming down the pike. I think left bundle pacing, as most electrophysiologists will agree, that in left bundle branch block, this serves to be a reasonable strategy that might become a part of the whole forefront of resynchronization strategies. Now, we know His bundle pacing became a big thing over the last few years, but has had issues with durability of the lead, as well as thresholds of the lead over a long period of time. And people have migrated, rather than pacing at the His, have decided to pace directly at the left bundle because the leads are secure and the thresholds, at least for now, whatever we know, are much better as compared to those in the His bundle area. So this has become a newer conduction system pacing strategy. This is to give you an example of a patient who actually failed an LV lead implantation, so could not get into the coronary sinus, but were able to do, again, intraseptal left bundle area pacing, and you can see that the QRS from 182 came down to 122 milliseconds. Again, this was a stylet-driven pacing lead, which is unusual. Usually we use the 3830, which is not a stylet-driven lead, but I don't want to get into the details of that. But again, indicating that it can certainly provide a source as a backup in patients who had a failed conventional CRT implantation.
Jack,
So
just sorry to interrupt. I wonder if I can just maybe do a couple of questions here. Barinder, who's our chief of cardiology, has a question about, what is the pathophysiology for ischemic cardiomyopathy? Is that predictor for response to synchronization? Maybe do that. And there's one more question maybe after.
Sure, absolutely. That's a great question. So I think we recognize that when you have some scar burden, that the remodeling process in the heart, even if you have a classic left bundle, but you have scar, those patients don't remodel as well as patients who don't have a scar. And that's because of the stress and strain of cardiac contractility, and the remodeling process is much more different. So we've done studies, and specifically in ischemic cardiomyopathy, and these are larger studies too, as well as the conventional RCTs have shown that patients with ischemic cardiomyopathy don't do as well. Not only that, if you get the lead over an area of scar, then the chance of actually capturing viable myocardium and remodeling the heart is not possible. Second is, if you get the lead in an ischemic zone, which is not scar, but there's ischemia there, again, the potential for recruiting the myocytes appropriately and having an appropriate remodeling process, again, is limited. So the answer to the question in a simple way is that ischemic cardiomyopathic patients don't do as well, but many of them do well also. So I think, again, out here, individualizing the strategy, understanding the scar burden, and trying to avoid the scar and the ischemic zones while implanting the lead is really important in ensuring response.
There's one more question that asks, is there a difference in response in patient with left bundle and left axis versus normal left axis and left bundle?
That's a terrific question. Somebody must have read our paper at some point in time. So we've seen this in small groups of patients. Obviously, this has not really made big time news, but we've noticed that patients who have a left bundle with normal axis actually do better than patients with a left bundle with a left axis. And I think a part of that is when you have a left bundle with a left axis, that means there's preferential delay in the left anterior fascicle. So that means, again, getting the lead in just the lateral wall may not work as well as getting a lead in the anterolateral wall, where there's more preferential delay within that left bundle. I mean, some of this is speculation, and much of this is also retrospective in the way we've looked at this data. But your question is a good one, and I would say, if I had to answer that question, I would say yes. Patients with the left bundle with normal axis do well with conventional lead positioning, whereas those with the extreme left axis or an extreme right axis don't do as well. But I think they potentially could also do well if we were able to individualize our lead location a little better.
Great, thanks a lot, Jack.
Absolutely. So there are a lot of exciting things within this realm of conduction system pacing in the heart failure patient. And this is just an example of an 81-year-old from a colleague of mine, Pugal, who all of you recognize as, I think, could be called as the father of his bundle pacing for sure, or the resurgence of his bundle pacing. That probably would be a better term for him. But there's a sequential approach now that you can do for an optimal CRT patient. You can do a his bundle, you can do a left bundle, you can do a left bundle non-selective, you can do an LV lead placement, and then you could do left bundle optimized LV pacing. So I'm not going to get into the weeds out here, but I do want to show you this particular case. As you can see out here, has a left bundle. This patient then had his bundle pacing with the QRS narrowing from 210 to 150 milliseconds. It was a really high threshold, so obviously it couldn't work. So that's why left bundle area pacing was done, where the lead was put intraseptally into the interventricular septum. And then we found that, again, the QRS out here narrowed, but not so much. Then a biventricular pacemaker lead was implanted, a CRT lead was implanted, and then a combination of the two was able to narrow the QRS to 144 milliseconds. So again, suggesting that we need to start thinking of better ways of individualizing our treatment strategies. So a patient may not respond to conventional CRT, but yes, we have other approaches that we can actually maximize the response in those patients by adding an extra lead or catching the conduction system in an innovative way that hasn't necessarily been done in the past. So at the same time, there are endocardial pacing strategies, and the endocardial pacing strategies are, this is a trial that we're doing called the SOLVE CRT study. We're doing this in Australia, Europe, and in the US. This involves putting a small little endocardial electrode into the intramyocardial space. As you can see out here, we go retrograde across the aorta, leave this endocardial electrode out here. This endocardial electrode is then stimulated by this battery pack, which is connected to the ultrasound transmitter. This ultrasound transmitter transmits energy to the LV electrode, and that electrode converts the energy into electrical energy, and therefore you can have a leadless way of pacing the heart in patients that were not responders to conventional CRT, or an LV lead, or a his bundle lead, or a left bundle lead, or not potentially implantable, giving us many options now of, again, individualizing our treatment strategy. This is the leadless future, I think. I mean, we're not there as yet, and it kind of looks a little grotesque when you look at it, but you can imagine that all these battery packs are going to get conventionally smaller. So you can imagine a patient with heart failure with a low ejection fraction and a wide QRS getting an ICD, which is subcutaneous. You can then see the patient needing a pacemaker inside, and that's a Micra, which is again a leadless pacemaker. And then you can have an ultrasound transmitter that is connected to the battery that feeds this endocardial electrode. Everything is in the subcutaneous space with two leadless and endocardial electrodes, suggesting that the future is potentially extrathoracic and leadless pacing, because that is safer for all that we know, and it allows us to get where we need to get, and without the potential complication of having leads within the heart. I'm going to shift gears here from cardiac resynchronization therapy to some of the other pacing therapies that are available in heart failure. And one of the exciting ones that has really risen to the forefront in the last couple of years, although has been around for 15 years, but recently got an FDA breakthrough status, is cardiac contractility modulation. Cardiac contractility modulation is a therapy that involves giving a high voltage impulse during the absolute refractory period of the QRS. This causes sarcolemmal calcium release. This in turn upregulates the SERCA and the phospholambin and the ryanodine receptors. That translates into an improvement in NYHA class, as well as peak VO2 consumption. And there is early data now from the FIX-HF5 and 5C study that this also reduces heart failure and mortality events. So again, indicating that CCM in patients who are narrow QRS with an ejection fraction of 25 to 45% on optimal medical therapy who continue to be NYHA class 3, CCM is an option that we can certainly resort to. Again, studies need to be done to look at long-term outcome and mortality in a randomized fashion with more longer-term follow-up. But the data is fairly convincing the way it sits right now, and there are ongoing studies to further prove whether it really works in patients on a long-term basis. In terms of heart failure, I think we all recognize that heart failure has central sleep apnea as an associated factor. We know patients who have heart failure and central sleep apnea actually do poorly as compared to those who don't have central sleep apnea. And there's this whole sympathovagal balance and autonomic upsetting of the balance that is a contributing factor to this. So there is the respicardia device, another electrical therapy that involves putting a sensing lead into the azygous vein and putting a pacing lead down the pericardiophretic vein. And this combination of sensing and pacing has been shown to significantly reduce the apnea-hypopnea index over a 5-year period, significantly across the board in patients. This still needs to be shown that it actually translates into better clinical outcomes. But again, another therapy that has gotten breakthrough FDA approval for patients with central sleep apnea and heart failure. I'm going to shift gears again and talk about neuromodulation therapy. I think this is a really exciting arena. It's the black box of electrophysiology and heart failure. And I think there are a lot of careers to be made in this arena. We know that carotid sinus stimulation, vagal nerve stimulation, spinal cord stimulation, renal denervation, stimulation of the aortic arch bed where you have baroreceptors there, as well as stimulation of the pulmonary artery, aortopulmonary trunk where you have the vascular bed with a lot of autonomic ganglia out there, are also potential areas for stimulation and modulating heart failure. So let me just go through a few of these, which I think are really gaining traction and might actually make a mark in how we treat these patients in the very near future. So carotid baroreceptor stimulation, this basically involves EPs and heart failures working with vascular surgeons where a device is implanted in the pectoral region, but the lead is tunneled up across into the carotid area, and there's a lead that is sewn into the carotid bifurcation out here. And what this basically involves is that by stimulating the carotid baroreceptors, there is a change, there's a reduction in heart rate, there's an improved vasodilatation, there's a shift in the sympathovagal balance, and this has been known to translate into better improvement in NYHA class, reduction in the pro-BNP levels, at the same time improve quality of life and peak VO2 consumption. And you can see out here that the early studies, the Barostim HF study, showed that it really improved 6-minute walk test as well as quality of life and NT-pro-BNP levels. And the BEAT HF study, which was recently published and recently presented, showed that it actually translates into better longer-term outcomes too, again, achieving breakthrough FDA status, and again is now being tested prospectively in larger studies in randomized controlled trials. The other neuromodulation therapy that I think has been again in play for the last 8 to 10 years for sure in randomized clinical trials is vagal nerve stimulation. And this is one of our patients where I work with the neurosurgeon to get the lead up into the vagus nerve area and then put the other lead in the right ventricle, connected to the vagal nerve stimulator. This is a patient with an ICD who had a narrow QRS and had refractory heart failure. Unfortunately, many of the vagal nerve stimulation studies, such as the Nectar HF study and the Innovate HF study, were neutral to negative. I would say just neutral. And now we have the Anthem HFrEF study, which is actually looking at 800 patients to see if stimulating the vagus nerve can modify the sympathovagal balance that can enhance the remodeling of the left ventricle and the right ventricle in patients with heart failure. I think the big problem with prior studies was a variability in lead designs, different stimulation protocols, dissimilar titration. And my pet peeve for autonomic studies is that really we're not using appropriate phenotypic markers for selecting our patients for these autonomic interventions. So for example, we don't really choose the patients with the appropriate sympathovagal balance who may actually improve with modulation of the sympathovagal balance for these therapies. And I think we need to be better in patient selection. We need to have better ways of dosing and assessing the impact of the dosing of the autonomic stimulation. So there's a lot of work that still needs to be done on the autonomic front. This is another study which was presented as a late breaker at the Heart Rhythm Society, and some of our work together has shown that stimulating the tragus nerve actually can reduce P-wave alternans and can reduce the AF burden But at the same time, I think the important thing is that there is evidence that tragus nerve stimulation, which is connected to the vagus nerve out here, can shift the sympathovagal balance. And then there has been evidence that it reduces AF and VF inducibility. At the same time, there's also evidence now that it can remodel the left ventricle, and the TREAT-HF study, which is a tragus nerve stimulation study, is currently underway. The other neuromodulation study, which again is investigational, I have not participated in this, so don't know a whole lot about it, but just the fact that denervating the pulmonary artery trunk, so taking a catheter up into the pulmonary artery and burning areas out there, you can denervate it similar to renal nerve denervation. And denervation out here has been shown to improve pulmonary hypertension and treat patients with left-sided heart failure. So a lot of I would say, exciting strategies in the pacing world, whether they are coronary sinus strategies, left bundle pacing, his bundle pacing. We didn't talk about multi-point pacing, but you can pace from more than 2 spots from a particular lead and really capture more myocardium and resynchronize the heart better. We talked about endocardial pacing. You can have multi-site pacing, that is RV and LV lead combinations. And then obviously you can have cardiac contractility modulation, and you can have extra cardiac stimulation and neuromodulation strategies too. So really giving you a breadth of what the pacing and electrical therapies for patients with heart failure can be. Many of these are already here now. Some of these are just being fine-tuned in terms of their abilities to truly show whether they can remodel the heart and actually translate it into better clinical outcomes in the long term. So really an exciting domain out here. Now, when we talk about electrical therapies, I think it's really important to recognize that there are sensors in these devices, and there could be simple sensors. These are heart rate sensors, accelerometers that measure physical activity. The sensors in the devices can measure the fluid in the lungs through a transthoracic impedance. These sensors can measure heart sound intensity as well as respiratory rate. So there's a lot of data that we can get from these sensors that oftentimes goes unbeknownst to us, not even noted until the patient presents in heart failure to our clinics. And there are a wide range of sophisticated sensors, which are beyond the scope of this particular talk, that are coming into play right now. Many of them, again, already exist right now and are being investigated. The intent out here being is, can you use sensor-based strategies with virtual care, with machine learning at the back end to really take care of patients remotely now? And I think in certain heart failure subsets, that is certainly possible. But let me give you some examples of how this can potentially help. So this is a study we did when we got interested in sensors almost 10 years ago. We looked at sensors that could measure the HRV, that is the standard deviation of consecutive RR intervals, the mean heart rate and physical activity. And just through these 4 simple sensor measures, we could actually distinguish. And we created the risk scoring strategy from one study in 800 patients and then validated it in 1,200 patients. And the bottom line out here is that if you have all of these abnormalities in the sensor approaches from within the device, you have an 18% mortality at 1 year versus a 4% mortality at 1 year, suggesting that you can use sensor-based device data now, this electrical data, to risk stratify which patients we need to look at more closely and which patients we need to follow more closely. And in the same vein, there is the integrated sensor strategies. And I think many of you must have heard of the HeartLogic, which is a sensor approach we helped work with Boston Scientific on, which is basically it can measure heart sounds, it can measure transthoracic impedance across the chest wall, it can measure physical activity, it can measure respiratory rate, it can even measure posture if the patient is symptomatic and needs to sleep at an elevated angle, and also measure heart rate and arrhythmias. All of these put together create something called a HeartLogic index. And when you track this HeartLogic index and you see it within patients, you can see that almost a month before patients develop heart failure, you can see a change in that HeartLogic index, and you can predict which patient actually is going to be admitted with heart failure. And so these are strategies now that are being used to inform providers to interrupt the cascade of events leading to heart failure But the hope is that there will be some closed loop systems that will also manage to help us take care of these patients a little better. So there are many implantable sensors. I think all of us know of the implantable loop recorders. There are sensors that are there in the right atrial leads. This is a part of the sonar study, which can measure cardiac contractility. There are sensors that you all know of called the CardioMEM sensors. That is a sensor that is implanted in the pulmonary artery that can measure pulmonary artery pressures over a period of time. And then obviously this is a study that we did implanting a sensor in the left atrium. And we could then monitor the pressures with the sensor device using a handheld device. Obviously, this has not come to the market because of some safety issues with the way it was implanted. But nevertheless, there are a host of sensors out here that can give us an insight into what the cardiac status of our patients are. And then there are a couple of new ones, again, a PA pressure sensor, which is implanted in the pulmonary artery, but is connected to the patient. So it provides us information through a management system of heart rate, blood pressure, weight, oxygen saturation data. And then you have the VLAP system, which is again another system across the interatrial septum that can measure pressure directly from the left atrium. So there are many sensor strategies incorporated in these devices that allow us the ability to monitor patients remotely and potentially intervene in how they actually do. I think the issue out here is largely that these sensor-based strategies often require heart failure and EP working together. They often require us understanding these devices and trying to share these patients so that we can get the best information out of these devices so that the information that is shared can then translate into better outcomes in these patients. And I think the real way we really need to look after these patients is not by trying to own them, but trying to, I think, work together. And work together is where we can bring the heart failure and the EP communities together, understand all this data that is coming in, help us better select patients, help us better manage these patients, and at the same time, I would say share the data so that we can look after these patients together. On that note, this is, Sheldon specifically asked me to kind of introduce some concepts on the integrated clinic that we have at Mass General. This is something we started in 2006. And we started this because our patients with heart failure who are ambulatory with implanted devices, as we all know, are a frail group of patients. They get disjointed care from an EP doc, a heart failure doc, the general cardiology, imaging docs. We found that there was no structured crosstalk in how these patients were getting their care. And we felt that the existing model of care was really deficient in evaluation of their response and recognizing who were non-responders, in transforming non-responders to responders. We were not using these heart failure diagnostics and better managing these patients. And we were really not understanding drug device interactions. And we didn't know when to optimize these devices. And we thought that if we brought all specialties together, each specialty really has a lot to contribute, which I think others may not necessarily be able to fulfill. And so bringing them together as a one-stop shop actually was something we undertook in 2006, and it continues to go on as a really neat healthcare delivery model where the patient arrives in the clinic area and is seen by all three providers at the same time. So what this construct basically involves, so this was something the hospital obviously was not excited about. They didn't know what the value of this was. And we said, just give us space and we'll figure this out. So we got 5 exam rooms with a 6-minute hall walkway. They're right in front of our exam rooms. We have a 50-foot walking area so we could make every patient into, we wanted to kind of make this almost look like clinical care and in the form of a trial where they get their best care. So we had 6-minute walks as a regular part of their evaluation. We got the equipment. Multidisciplinary clinic. This is one of our virtual multidisciplinary clinics. This is our heart failure physician, Dr. Newton Che. This is our patient. This is our nurse practitioner, Mary Orancole. This is myself. This is all of us looking at the device diagnostics within the patient, actually explaining to the patient what your physical activity is, what your pacing rates are, what your transthoracic impedance is, and really integrating our services to the patient to provide the best possible care. And we have, as I showed you, really transformed the way care was delivered to these patients. And you know, at the same vein, I would say that this, at any given time, we would have about 20 to 25 clinical trials running through our program. And this obviously led to several hundred publications and several people benefiting their careers from this integrated care clinic. So I know we're running out of time. In summary, I would say that we talked about resynchronizing the failing heart. We talked about conventional CRT. We talked about some of the newer pacing approaches, such as left bundle, his bundle, and other pacing approaches. The future for individualized care. Thank you very much for your kind attention. All right. I hope I finished in time. I know you stopped recording in between.
Thanks a lot. No, sorry, Jack. I lost power in my house, so I think I don't know. It's dark, and I'm using my phone to power the Zoom meeting. So I hope it was okay. So it's stop and go. I don't know. It's kind of interrupted. So now it's all dark. Sheldon, do you want to get started? I'm still looking to see how I can connect again.
Jack, thank you for the talk. This was fantastic, like an amazing overview. And I have a ton of questions, but I'm going to just ask one to start with. I was fascinated by the paper you guys had with the multidisciplinary clinic during the pandemic. And, there's a push now to see patients in person, but, things will never be the same. And we've developed some efficiencies by providing virtual care. I guess I'd like to get your experience on your transition back now to seeing patients in person and what's with your virtual clinic. And my specific questions are, there's a ton of information on these sensors. How often do you think that avoids the need to actually see someone and look at a JVP? And, what proportion of patients do you think will stay on this kind of virtual platform? So just so I can get a sense of how you think your workflow will be going forward.
Right. So let me talk about the pendulum swinging back on virtual care overall, not just the integrated clinic. I think that's become an issue, and I think it's become an issue largely because, I think, at least in the US, I think it's a financial issue. I think it's fiscal viability. I think when you see patients in person, you order more tests in the hospital and everybody makes more money. And I think that's unfortunate, but some of that pendulum swinging back is related to that. The other thing is also the people who need virtual care the most, the ones who are living the furthest away or out of state, are the ones now with regulatory bodies intervening, saying that you cannot look after patients who are out of state. So that has become a bit of a problem. So yes, I think we are falling back to our old ways, which is a travesty, because I think we should have learned from the pandemic as to how clinical care needs to be delivered in the future and start adapting and moving in that direction. Because I think healthcare overall is non-sustainable in the current model that is transactional, in the current model that requires us to see every patient constantly in clinic in person, not just from inconveniencing them to come to see us, but at the same time for us to actually have to make the space and access and availability and all the other things that become a problem. So I see the pendulum swinging back, and we're trying to titrate it. So one of the things, I lead the Department of Medicine telehealth program. I'm kind of one of the co-chairs out here, and we're trying to find use cases that we think should be translated into long-term strategies for these particular cases, whether they're diabetes, whether they're hypertension, whether they're heart failure patients who are in transitional clinic care pathways. Should be seen virtually, at least for a certain subset of visits, and then they should be alternated with in-person or so. So that strategy is developing. But I do think we haven't been forceful and fast enough and nimble enough like we were during the pandemic to really come up with those strategies and use cases. The second question is about sensor-based approaches. So I think, I don't need to tell you that the future of clinical care is actually, I mean, if you look 10 years down the line, we may not see it right now, but is going to be virtual, that is sensor-aided, and that is powered by predictive analytics and AI or machine learning, whatever you want to call it. I think that is the future for sure. And I think all of us collectively have to start recognizing that and moving in that direction, however painful it is going to be initially. I think it'll be, it may be complex now, but it'll become simpler much later on. So to answer your question specifically, how often is the sensor data, good enough that you do not require to see a JVP? So I think, there's nothing as good as the physical exam and really laying your eyes on the patient. But at the same time, I think you and I both know that, 60% of cardiologists, leave alone internists, are not great at measuring the JVP. And I'm sure not many of us even look at the JVP. And there are a huge segment of clinicians who are not even putting their stethoscopes now to the chest wall of patients. So I think sensor-based data is objective. But I think a single sensor data point, like the transthoracic impedance that measures the fluid levels in your lungs, can have false positives and throw you out of whack. I think whatever sensor-based data strategies that we adopt have to be integrated strategies. That means we need to be looking at more than one sensor variable and seeing if all those sensor variables are lining up in the right direction, and then deciding if that really kind of fits in with the clinical picture. So I think in isolation, looking at a sensor data point would be silly because it may be completely out of context. And I think it needs to be put in the context of the patient and with other sensor variables. And that's one of the reasons why I showed you that multi-sensor strategy did well in predicting which patients will go into heart failure, is because it's an integrated blended sensor that looks at all these covariates and then tries to put it together, whether the patient is truly doing poorly or not. So I know this is a kind of a long answer to a simple question, but I think it's not a simple question. It's a complicated question, and I think much is evolving on this forefront.
Thank you.
Of course.
So I think there's another question from the audience, which is, do you routinely use echocardiography for optimization in the clinic? And I think that's a good question because there is some, data to suggest that it may not be done right in the proper hands. So we'd love to have your take on that.
Sure, absolutely. So the answer is we used to, and when I say we used to, I would say up to 3 or 4 years ago, almost every patient would get echo-guided optimization in our laboratory. We'd do it at 1 month when they came in to make sure they were optimally programmed, and we do it again at 6 months. And then it became logistically challenging. That's one. And second is that there were now automatic optimization strategies like adaptive CRT, like Sync Fusion, like Smart AV, that are programmable features in the device that are more dynamic, that adjust to activity and take into account the intrinsic conduction system of the heart with activity, which the echo-guided optimization doesn't necessarily do. I mean, where in an echo-guided optimization, you're lying on your side in a semi-recumbent position, you're looking at hemodynamics in just one particular position. And then the respiratory cycle, as you know, significantly can change the velocity time integrals. It can change the filling patterns of the left atrium, which have their own issues. So we had a very systematized, organized way of doing echocardiograms, which was very reproducible, which I know is not the situation in a lot of centers because you need to be doing them a lot and constantly to really be good at it. So the simple answer to your question is we don't do them now in every patient. We do them in patients who are truly non-responders to conventional strategies and with automatic optimization. Then we'll do an echo-guided optimization and then decide if there's something else that we need to do.
I think Harindra and Dennis have questions. Harindra, do you want to ask your question?
Sure, thanks. Great talk. I might have missed this. It's fascinating how many different pacing options there are now. So how do you decide? Like, do you decide in clinical care now, recognizing that some of them aren't quite mature enough? Do you do it on the surface ECG? Does everybody need an EP study for it? And if so, like, how tight is what you see on the EP study to decide which of these options is the best one?
Right. No, that's a great question. I think there will come a time when we will need to better phenotype our patients to individualize our therapy. At this point in time, if I look at it simplistically, you have a narrow QRS and a wide QRS. And within the wide QRS, you have a non-left bundle and a left bundle. All the data for wide QRS pacing right now that has randomized controlled clinical trials are CRT options, are conventional cardiac resynchronization therapy. So, and if patients don't respond to conventional cardiac resynchronization therapy, then you can go down the path of alternative approaches such as left bundle area pacing or his bundle pacing, because there's really not much data. In fact, there's no data in terms of left bundle or his bundle pacing in the form of a randomized controlled trial with long-term follow-up. So I think you're obligated to use strategies that are conventional. Now, if you do conventional pacing and patients don't respond, then you start working your way down the path of the different pacing strategies that you said. I would go down the most non-invasive approach in those particular situations. So if single point left ventricle lead didn't work, I'd do multi-point. If that didn't work, I'd optimize the programming. If that didn't work, then I would try a left bundle area pacing if they have a left bundle branch block or alternative pacing site. So I would systematize it from non-invasive to invasive. And again, this is more of a personal perspective. There's really no clear randomized trials suggesting what are the approaches in non-responders in a sequential way. I think there's so much of heterogeneity within patient profiles within these heart failure patients that there's never going to be a one-size-fits-all strategy. So I think a lot of it comes to, I would say, experience, but also trying to phenotype these patients thoughtfully.
So maybe I'll ask a question, Jack. I wonder if you have a crystal ball about the devices like phones, Fitbit, and things like that. There's obviously the Apple iWatch study that had a lot of attention, which is kind of done at Stanford. I just wonder if you have a crystal ball about these, what we use every day. Like, what do you think it will pan out, and what are we going to use? Because the patient now calls us a lot, right? I've got AFib showing, what to do with it. It's, sometimes a bit annoying. I just wondering if you have any thoughts about those type of devices.
Absolutely. So I think the world of wearables will overtake the world of implantables for sure. If you can wear a vest and get, every organ sensitized sensor data from, your heart rate, your heart rate variability, your blood pressure, your oxygen saturation, your peak VO2, which now is also available in a watch, you're going to have much better compliance and willingness. And that also needs to be kind of seamlessly transmitted, seamlessly collected, seamlessly annotated, curated, stored, and then analyzed. So there are many parts to it that I think are still evolving. But if you ask me my crystal ball and my kind of, the thinking cap, I'd say for sure that the wearable strategies are going to make headway. They're going to make headway even into the heart failure space. So if you look at, any patient from chronic heart failure that decompensates into acute heart failure has an underlying substrate first. They have an abnormal sympathovagal balance. They may have diabetes, hypertension, ischemic heart disease, right? Now, all four of these variables can be measured from the watch or from a wearable right now. Then these patients can have triggers, and that can set them off PVCs or AFib. Those can also be measured from a watch. Then you have, changes in heart rate variability, oxygen saturations that can predict which patients are going to go into heart failure. Those also can be available from a watch and from, other sensor strategies that are available. So you can only imagine that if you had the right ability to process these data in the context of that particular individual patient, that wearable data will be used to risk stratify patients for decompensations for heart failure or for AFib or any other clinical situation. And I think for us to start adopting those and understanding that those are going to become a part of our workflow, whether we like it or not, because patients are going to ask for it. And that's where the way the market is progressing. I think it's something we need to start really paying attention to, because that is the future for sure.
Great. Maybe just very quick question. Cardiac arrest, is it like, do you anticipate something like with all these wearables, all these data to kind of say, well, this is a trigger, you're going to go to VT, VF soon, you're going to rest? Like, is there something that's close, or is it just too heterogeneous, you think?
So, people have obviously looked at, for example, if you look at the study from Mayo Clinic, they've looked at a 12-lead EKG, right? And from a 12-lead EKG, they can predict which patients are going to develop LV dysfunction over a 20-year period, or develop sudden cardiac death, or develop atrial fibrillation. Can that happen from a watch EKG in the future? Totally possible. It's just that you need the data set and you need the follow-up to be able to conduct those analyses over millions of people's data. And I think that kind of data will be available from watches. It's just that you need the outcome data out there to really kind of create the right neural network strategy, deep neural network strategy for analyzing those signals. We're doing some studies. For example, it's called the Watch QT study. We participated with that in France, and right now we're doing it at Mass General, where we're actually looking at patients who are getting drug loaded for AFib with Sotalar or Defitelide or Amiodarone, and we measure their EKG off the watch, as well as a 12-lead EKG. And there's a cloud-based system that uses an algorithm to measure the QT interval off the watch to see if it compares with that from the surface EKG. The intention out here being to be able to do some of these, drug altering strategies at home rather than in the hospital like we do it conventionally, at least at Mass General. But just to, kind of further your question, it is possible that those QT interval measuring strategies, also the dynamic strategies, will help us also in predicting which patients may be more vulnerable for sudden death and other arrhythmias. So there's a lot happening in the space. And I do feel that in the future, we will have, some of it is pie in the sky right now for sure. But I think we will have data and processing strategies that will make much of this possible in the future.
Great, thanks a lot. Sheldon, do you want to say final word? Yeah, go ahead.
Yeah, no, Jag, thank you so much. This was a fantastic talk, an amazing overview. You've let the audience know that electrophysiologists do a whole lot more than simply put catheters in the heart. I've learned a lot, and I'm sure that the information you provided will help our group evolve. Thank you, everyone, for coming to the rounds. And again, on behalf of the Division of Cardiology at Sunnybrook Hospital, thank you, Jag, for attending.
Thank you. Great to be here. Appreciate
Thanks a lot,
the
Jack.
invitation.
Okay, thank
Bye-bye.
you.